So transforaminal injection, there's a few reasons to do those over interlaminar. One is we want to be very selective. So the surgeon comes to you and says, hey, I think this patient has an L4-5 or an L5 radiculopathy, right? So we're going to do an L5-S1 and just keep the medicine there, right? When we do an interlaminar, it's going to go about 3 levels up, 3 levels down. When we do a transforaminal, we can really do a small amount of volume, 1 cc of dex and maybe 1 cc of marketing, and just keep it all in that area. And then you get that diagnostic value out of it, right? So not only are you helping the patient with the therapeutic value of putting the steroid in there, but you're getting that diagnostic value. Another reason is that, let's say the pain's all one-sided. Most of the time, radiculopathies or the disc bulge pushing on the nerve will be one-sided. So, and we want to get the L4-5 and the L5 nerve, because a lot of people don't understand, and if we had we should have some MRIs, but at an L4-5 disc bulge, a lot of times you'll get that traversing nerve root going out at L4, but you'll also get the descending nerve root at L5. So a lot of times I'll do the L4-5 transforaminal and the L5-S1 transforaminal to get both the L4 and L5 nerve root. Because what you'll see all the time is the patient will have I see this all the time, patient has a central disc bulge at L4-5, right? And whatever doc did their previous injection didn't look at the MRI, I don't think, because it's a pretty central disc bulge. The L4 nerve's already out before this disc bulge is there. It's not compressed. You're actually compressing the L5 nerve root on the way down to the next level. They get an L4-5 epidural. Patient comes in and said the epidural didn't help. Well, you didn't. That nerve was fine, right? You didn't treat the nerve that has the compression. So let's show off just a 1 level. Shoot that AP again. 2 shot. Perfect. Come north a little bit. We're gonna go above. We're not gonna for their first transforaminal. I'm not gonna make them go around a fusion. That's not fun always to get around the bars. It's not impossible though. You can still do it. Shot. Good. So why don't we go at L2-3? So we say they have an L2-3 nerve compression. And your neurology, and I'm going to put you on the spot. So what nerve root? Well, what nerve root's at L2-3?
L2.
L2, right? So what dermatome is L2? Right there, right at the hip. Perfect. Good job, guys. So that's good. So we're going to treat, we'll go on the right side since we did the left side for the last one. So we're right in AP, right? Hold on. Oh. So we want to get right below that pedicle. I'm going to come over here and show you guys, right? So the nerve is going to come right out here, right below that pedicle, and go down. So we want to get around, there's a facet joint here, right? And give me that model. Perfect. So there's a facet joint here, and if we just try to go straight down, we're going to either bump into the facet joint, we're going to bump into the nerve, we're not going to get where we want to get. So we have to oblique a little bit to open this up. So let's oblique to the right side a little bit. And see if we can open up this space here to give us, keep going a little bit more. And this is our classic Scotty dog. Keep going a little bit more. Perfect. So it's easy to see the Scotty dog here. Here's the eye of the Scotty dog, the mouth, the ear, 1 foot, another foot right there, and the tail here. And the Scotty dog's looking that way. So I do all my procedures with the spine on its side. A lot of people do it straight up and down. The reason I do it on my side is 1, that's how we were taught in Birmingham, and 2, it makes more sense to me. The patient's head is here and the patient's feet is here. So when I need to go lateral, I go lateral. When I need to go medial, I go medial. It's not, you don't have to turn it in your mind. So this is how I was taught, and I think it works really well. So now, where's our target spot for a transforaminal injection? Is going to be right underneath the eye of the Scotty dog. The eye of the Scotty dog is the pedicle. We need to get past the pedicle to get into the foramen. So we need to be right below that pedicle. So I'm going to want to give myself more space here. So if we tilt to the feet, we're going to bring that pedicle up by tilting to the feet a little bit. So I'm going to tilt to the feet just a little bit. I can push it if it's open. There we go. Good. That's probably enough. And now we brought that pedicle up here, and we're going to right for that area right there. So we're going to right there. This, you can see the facet joint here. That's now out of our way. That's medial. We're not going to hit that facet joint. If we want to do a facet joint injection, this is actually the same exact setup for a facet joint injection. Also same setup for a medial branch block, right? Medial branch is right on the eye of the Scotty dog. Facet joint injections are kind of out of favor these days. We don't really do those for facet joint pain. The only time I do those is if there's a cyst and we're trying to aspirate that cyst. And it only works about 10% of the time, but it'll save the patient a surgery. Because if you can't aspirate that cyst, they go to Dr. Cantor because it has to be removed. Because that cyst is like a hard thing pushing on that nerve. That's not going to move. So we do try to aspirate cysts. It doesn't, people will say they get it 50% of the time. I'd say it's 10-20% of the time, but it's worth trying. And what more is in favor now for facet joint pain is the medial branch block. So we're going to show both of these from this procedure, from this setup right here. So first I'm going to do a transforaminal, then I'll do a medial branch block here. We're going to go in this view, then we'll go lateral, and then you guys will try it, okay? Picture. So we want to be right on beam when we start. So why would someone have a transforaminal injection? Main reason, shot, is usually a radiculopathy or radiculitis, where the patient has sciatic pain, as everyone knows it, shooting down their leg, and the main cause of that is usually disc herniation. Depending on age, it's usually disc herniation, foraminal stenosis due to other reasons of the spine, such as facet overgrowth or ligament overgrowth. So, let's take a shot. We're right under that eye of the Scotty dog. Remember that pedicle there? That's right where we want to be. In the AP, now you want to stay high in the hole. Why do you want to stay high in the hole? What's low in the hole? The nerve root, right? So go lateral. So we don't want to hit the nerve root or else the patient's going to jump off the table. So we're going to go lateral here. And why do we go lateral? To check our depth, right? So we're going to put that one on the right. Perfect. So now we have a beautiful lateral. This imaging is great, actually. So we can see the foramen here. This is the foramen right here. And you can actually see what looks like would be a nerve root right there. See how the nerve root is low in the hole? That's where it lives. We want to be as high in the hole we can because we want to be I always tell my patients, I want to be in the nerve root's home, but I don't want to touch it. Because if you touch it, it's going to hurt a lot. And what we're going to do, so we just check, all you check a lateral for is for depth. We don't put any contrast here yet. So we're going to come AP. So we know we're deep enough. Because sometimes you could be back here, you think you're in, you're not there yet. You want to be deep enough. You don't want to be too deep. If you miss the vertebrae, you can go past the vertebrae, you know, and someone with different anatomy. You don't want to be too deep. So now we know we're here. Come back to a perfect AP, and we put contrast in here. And once again, we're not going to put contrast, but what's that contrast flow we're looking for? And everyone will talk about this. You want to see it flow around the pedicle here. You'll see it flow around the pedicle. You'll see it flow down the nerve root. So it'll look kind of like an S, okay? Around the pedicle and then down the nerve root. And that's what we're looking for. Once we have that good contrast pattern, we're going to put the medicine in. Once again, selective nerve root blocks, I would do one Addex, one Amarcaine. If we're doing a 2-level block, I usually draw up a solution of about two Addex, 2 Amarcaine, 4 saline, somewhere around there, and split it between the two areas because I'm really trying to treat that disc bulge and treat that nerve irritation. So that's transforaminal. Do you guys want to give it a go?